So let us look at electrocardiogram in acute coronary syndrome, what and when to do. So I have prepared this topic as an interactive format. So many of the questions, basically the ECGs you may be able to interpret, and also the plan and subsequent management. But anyway, we'll have it as a revision as well as an interactive format. So it is just like we are doing rounds in intensive cardiac care unit or intensive coronary care unit. So each one of the ECGs belongs to each one of the patients, and we are going to plan the management for each one of these patients with those ECGs. So before we start, whenever a patient comes with acute chest pain, the important thing is the patient should be seen immediately. The patient should not be waiting for the appointment with acute chest pain. So the patient should be seen immediately. The duration and the nature of chest pain should be immediately assessed. Then what is his hemodynamic status? So having made sure all the 3 points, we must take immediate electrocardiogram, and that electrocardiogram should be seen immediately. The important thing is any acute chest pain, you have to feel all the pulses and also auscultate for a murmur like aortic regurgitation or a mitral regurgitation, or is there any third heart sound or fourth heart sound. So all these things should be done within the initial 5 minutes of patients presenting with acute chest pain. So any acute chest pain, it is always go into 3 or 4 important points like the history, whether the pain is maximal at onset. So one of the important imitator of acute coronary syndrome is acute dissection. So problem is acute dissection also can have ST elevation because of coronary dissection. The important practical implication is that the thrombolysis is contraindicated in dissection. So if you miss dissection and you think it is STEMI and give thrombolytic therapy, it may kill the patient. So that's why in history, with a brief clinical examination, in ST, any ST elevation MI like presentation, you must rule out a dissection. In dissection, the pain is maximal in onset, whereas in ischemia or STEMI, the pain builds over few minutes or few hours. The clinical examination showed